first speaker is Dr. Karim Manji. He is a podiatrist and the director of the Zavat Limb Preservation Center, and he's the president of the Alberta Podiatric Surgeons.
So, thank you for the introduction. I'd like to thank Wounds Canada, the CPMA, and Dr. Ahmed Casey for inviting me to speak with you today about limb preservation clinics. These are my disclosures. These are the objectives here, but we'll start into the talk. The history of the team approach to the diabetic foot and limb preservation can be tracked back to this city, where the discovery of insulin almost 100 years ago was made at the University of Toronto. After the discovery of insulin, although mortality from diabetic comas dropped, there was a significant rise in secondary complications, including diabetic gangrene of the foot and leg. This was analogous to the seat belt or the airbag for motor vehicles, which reduced mortality, however caused an increase in orthopedic trauma that was not seen before. The first hospital foot clinic dedicated to the diabetic foot was established in 1923 at the New England Deaconess Hospital, which included endocrinology, vascular surgery, and podiatry. As we all know, diabetic foot limb preservation is a complex and multifaceted medical condition that requires input from many specialists. Studies have shown that a multidisciplinary team can reduce major amputations by up to 72%. Lee Rogers et al. Described the multidisciplinary team as a toe and flow model, which includes the key players of the limb preservation team. We'll do some live polling. If you have the app, you can answer the question on this slide. If we get a sense of why we should focus on major amputations, if we were to compare them to minor amputations, what would they be associated with? Significantly higher survival rates, a higher quality of life, a lower cost to society, and as we all know, it's D, all of the above. When comparing minor and major amputations, studies have reported a significantly higher survival rate and a higher quality of life for minor amputations compared to major amputations. Limb preservation is associated with a lower mortality and a higher quality of life and a lower cost to society. In fact, in Alberta, the cost of a below-knee prosthesis is approximately $7,000 a year, compared to $800 a year for a diabetic shoe and insole filler as demonstrated on the slide. In the toe and flow concept, the irreducible minimum in a limb preservation service is a podiatric surgeon and a vascular surgeon. This is the foundation of the limb preservation service. The podiatric surgeon can assess and triage patients that have ulcerations and surgically manage infections, help with advanced wound care, obtain bone biopsies, and perform limb preservation surgery, which includes minor toe and foot amputations. Vascular surgeons are an essential component. They not only revascularize the lower extremity, but can also perform limb preservation surgery. This collaboration has shown to be extremely effective, and later in my presentation, I will share with you our experience in Calgary of the toe and flow model. If we look at the different limb preservation teams, the capacity of the team is determined by the members of the team. Rogers separates them into basic, intermediate, and centers of excellence. I would say that every university and metropolitan city in Canada should strive to create a center of excellence limb preservation center. When we look at the basic model, primary team, the members of the team can include general practitioners, podiatrists, and diabetic nurses. These teams aim to provide preventative care and basic curative care. These teams are essential components to the surveillance of the diabetic foot, and they closely collaborate with the referral center. When we look at the intermediate or secondary team, the aim is to provide a curative care for all types of patients. These teams' capacity increases as the diversity of the specialists increases. The team members include podiatric surgery, vascular surgery, endocrinology, diabetic nursing, and others. The intermediate teams are generally located in hospital settings. Centers of excellence or tertiary teams are specialized in the curative care for complex cases. The teams consist of multiple specialists, including podiatric surgeons, vascular surgeons, endocrinologists, orthopedists, infectious disease, orthotists, diabetic nurses, and others. These centers also provide a space for knowledge sharing, practical skills training, and collaborate with referral centers and help develop local guidelines. This is another polling question. If you have the app, how would you describe the limb preservation team that you collaborate with? Our experience in Calgary has been one with many challenges and many rewards. The picture shown is of a sculpture designed by Yame Plenza outside the Bow Tower in Calgary called Wonderland, and it depicts a young girl's head. The inspiration came from his belief that, I quote, "The architecture of our bodies is the palace of our dreams." Our toe and flow model started about 20 years ago, in 1999, between the collaboration of one podiatric surgeon and one vascular surgeon. We now have a team of 6 podiatric surgeons and 7 vascular surgeons that are all dedicated to limb preservation. If we look back to 1999, I would describe the model as basic or primary. At this time, podiatrists would see diabetic patients in private office settings, and it was difficult to collaborate with other specialists. Minor amputations were often performed in the main operating room, and collaboration was mainly for only inpatients. At this time, podiatry had a partially funded fee schedule in Alberta with a $250 annual limit per patient. This made treating patients with diabetic foot complications unsustainable. The next 6 years were difficult for the podiatric surgeons. Challenges arose when treating complex patients in hospital settings. Other medical specialists were unable to be reimbursed for a consultation if it was referred from a podiatric surgeon. However, the hard work and dedication of the podiatric surgery team helped create awareness locally and provincially, which laid the groundwork to be recognized by Alberta Health Services. During this time, it was common that the podiatric surgeons would often treat patients at no cost, often performing surgery, supplying post-operative dressings, and being available on call with little or no reimbursement. In 2006, Alberta Health recognized the value of the podiatric surgeons and developed a fully funded podiatric surgery fee guide to address the disparity, and this allowed the foundation for collaboration between specialists. This formal integration of podiatric surgery into the health system was key. Between 2006 and 2014, limb preservation surgery and minor amputations were starting to be performed in a minor surgery clinic setting, which is an outpatient clinic where only local anesthetic can be administered. This allowed for quicker treatment for draining abscesses, performing open amputations to evacuate the infection, and obtain deep cultures and bone biopsies. In 2014, close collaboration with vascular surgery, podiatric surgery, infectious disease, and internal medicine allowed for the creation of the Zivit Limb Preservation Center. Our aim is to be a center of excellence for the diabetic foot. Over the past 5 years, our clinic has grown exponentially. We started in 2014 in a hospital clinic with a half a day of clinic resources per week. This has now grown to a full 4 days per week clinic, and in the last 12 months, we have had over 7,000 patient visits. Earlier this year, we set out to investigate the efficacy of this toe and flow model in Calgary, and I will share with you some of the results of our research. We started by looking at the number of diabetics in the different health zones in Alberta. You can see that on the table that in 2007, there were close to 53,000 diabetics in Calgary and about 58,000 diabetics in Edmonton. As we track the diabetes population, you can see that in 10 years, like in other provinces, the number of diabetics had doubled to 107,000 in each city. Edmonton and Calgary are very similar in terms of population, age distribution, sex proportion, and the number of people in the labor force. More importantly, they are also governed by the same health authority, Alberta Health Services, and this made the comparison useful to evaluate the toe and flow model in Calgary. When we looked at the incidence rates of amputations in both zones, separating minor amputations and major amputations, we defined minor amputations as any amputation that involved preservation of the ankle joint, which included toe amputations, ray amputations, transmetatarsal amputations, and Symes amputations. Major amputations were classified as transtibial and above. After collecting the incidence rates for amputations for the diabetic populations, we adjusted the data for sex and age to compare the populations more closely. When we compared the number of amputations, Approximately 70% of the amputations were performed on males and 30% on females. It was interesting to note that the total number of major and minor amputations remained relatively similar, around 2,200 in both cities. When we plotted the data, we found that Calgary had a significantly higher minor amputation rate and a lower major amputation rate. Of the total amputations, 58% were major in Edmonton, while only 26% were major amputations in Calgary. After linearly fitting the normalized incidence rates for each zone, Calgary shows a stronger increasing rate in minor amputations and a stronger decreasing rate in major amputations, with a greater coefficient of determination. We can also see that the incidence rates are more coherent and more predictable in Calgary, and we attribute this to a centralized limb preservation center. We found that Calgary's minor and major amputation rates were significantly and negatively correlated. That is, for every one increase in a minor amputation, we were able to reduce one major amputation. It is important to remember that all of these minor amputations were only healed with a successful collaboration with vascular surgeons who were able to optimize the blood flow to the lower extremity. Overall, we found that a multidisciplinary team that included podiatric surgeons and vascular surgeons can reduce major amputations by 47%. Some of the barriers in establishing a multidisciplinary team that include podiatric surgeons continues to be the lack of knowledge of the role of the podiatric surgeon, government policy around the scope of practice, and reimbursement. Together, we can help demonstrate the efficacy of the toe and flow model to support the development of multidisciplinary centers. However, we will need the podiatrists from across the country to get involved and work with their local allies, vascular surgery teams, even if that means volunteering, to help build a multidisciplinary team. Thank you.